Good day, everyone. So we are on our 22nd session of Learning Basic Arthroscopy series of lectures. Today we have a very important and very interesting lecture. It's going to be on dedicated talk on complications of ACL reconstruction. Hey, everyone. So we are on our 22nd session of Learning Basic. Okay. So we have Dr. Vinay Kumaraswamy. Let me share my screen. Dr. Vinay is consultant arthroscopy surgeon and arthroplasty surgeon from Bangalore. He had done his fellowship in shoulder and upper limb surgery at Wrightington Hospital, UK, and is also trained in arthroscopy by Dr. David Rajan, Coimbatore. He is also a member of Royal College of Surgeons of Edinburgh. He has worked as faculty at KIMS Hospital, Bangalore, and is currently consultant orthopedic surgeon in arthroplasty and arthroscopy at Fortis Hospital, Bangalore. Welcome, Dr. Vinay.
Thank you.
And one of the other speakers is Dr. Francisco Figuera. We have a very, very long CV for Dr. Francisco. I won't be able to complete the whole CV today. So Dr. Francisco is consultant knee surgeon in arthroscopy, arthroplasty, and trauma of the knee from Chile. So he's going to talk about infections in knee after ACL reconstruction. Welcome, Dr. Francisco. And myself, Dr. Saseendar, shoulder and knee arthroscopy surgeon from Apollo Hospital, Muscat, and our Dr. Srinivas Kambhampati from knee arthroscopy and arthroplasty surgeon from Vijayawada. So we are here to welcome you for the program on complications of ACL reconstruction. Welcome, everyone. I hand over the program to Dr. Vinay to start his talk on complications of ACL reconstruction other than knee infection. Over to Dr. Vinay.
Yeah, thank you, Saseendar. Thank you, Dr. Saseendar, and thank you, Dr. Srinivas. Yeah, thank you very much for the opportunity to share some of my experience on complications of ACL reconstruction. Whenever complications happen, it's a little depressing scenario. We feel bad about that, but the point of doing any ACL reconstruction is to offer the patient a functional, pain-free, and stable joint. So, if any of these three parameters are not met, if the patient is not functionally happy, if the patient continues to have pain, and the patient doesn't have a stable joint, then that can be called as a complication of ACL reconstruction. And our job is to not allow any such complications to happen. But the point is, nothing worthwhile is ever without complications. You know, in this corona era, there's so many negative and depressing news that keep coming. Let us start with something positive. Complications are a part of any surgery. Complications happen with any surgery. So they do happen with ACL surgeries also. It is our job to be aware of those complications and not be afraid of them. As to say, a ship is quite safe in a harbor, but that's not what a ship is built for. So we have to go on with our ACL surgeries, be aware of the complications, and avoid them as much as possible. But things do, go south once in a while. So the complications that can happen after ACL surgeries can be divided into these 5 classes. Complications secondary to a fault in diagnosis and judgment of the case properly, error in graft harvesting, error in graft sizing. There can be a complication during placing the graft and fixing the graft. There can be complications after the surgery during the post-operative care. So we'll go through them one by one. I've made a table of such complications. First, we'll start with complications that can happen while if you don't make your diagnosis properly, if your judgment is improper. Performing surgery too soon can be a complication. If you perform the surgery too soon, historically, it is said that it results in post-operative stiffness, cyclops formation, and suboptimal results. So the recommendation in earlier literature was to postpone the surgery till full extension is achieved and till 90-degree flexion is achieved, and till such time you should postpone the surgery because it results in poor post-operative movement. And how to prevent it is through aggressive physiotherapy. That was the teaching earlier, but then again, we published our own study in 2018 in Journal of Clinical Orthopedics and Trauma, where we compared 104 ACLs. 53 ACL surgeries were done before 3 weeks of injury, and 53 were done post 3 weeks of injury. The range of motion, IKDC, and Tegner scores all were better in the early in the cases whom we operated early, and there was no clinical difference in the post-operative motion or functional results in both groups at 1 year. So the literature and the experience is a little dichotomized, bifurcated when this is concerned. Performing our experience of performing surgery even at 1 day, 2 day post-op has been quite gratifying. All patients have recovered well. There's no cyclops formation. The point in that is whenever the patient is acutely injured, they don't have full extension nor do they have 90-degree flexion. But once you put them in anesthesia, the full extension and flexion will come unless it's been a chronic case. So our experience and the literature we published shows that it is advisable to do ACL reconstruction early as well in the immediate post-op period as well. However, one has to be cautious while performing surgery too soon. Then there can be cases where you end up performing the surgery too late. In case the patient comes in too late into surgery, they can already be damaged to the meniscus or cartilage. It's important that if the patient doesn't agree to surgery immediately, then we'll have to take an informed consent about the complication that might happen because of delaying surgery, give him proper bracing, and do not operate on any old MRI. Whenever the patient supposedly has a 6-month-old MRI comes in for surgery late, get a recent MR done and check what exactly is wrong in the recent MR and treat lesions as such. And who are the ones who need ACL surgery? Earlier, the teaching was that only athletes need ACL surgery. The natural history that we understood now shows that the knee undergoes quite a lot of pathological changes to the cartilage and meniscus if we don't operate them. So most of the ACL surgery, complete ACL tears would need a surgery. It's important for us to convince our patients and make them understand that it's imperative that they undergo surgery if they have a complete ACL tear. In case they don't agree and come in late, we have to inform them how to avoid injuries by not getting into sports and bracing properly, get a recent MR done. The most important error in judgment happens if you don't pick up injuries on the medial or the lateral side of the knee while doing an ACL reconstruction. It's very important to pick up the medial collateral ligament or the posteromedial corner injuries and the posterolateral corner injuries, perform a proper valgus stress test, varus stress test, identify those injuries and address them while doing an ACL surgery. Any clinical exam is incomplete of the knee is incomplete without a varus stress test or a valgus stress test to pick up the posteromedial corner. I would like to touch upon the dial test. Dial test is a part of our examination during the clinical examination in the clinic and after anesthesia as well. This is the dial test in 30-degree flexion. This is a patient of ACL, PCL, and TLC injury. You can see at 30 degrees the dial test is frankly positive, and at 90 degrees also the dial test is frankly positive. So examination under anesthesia is a very, very, very important part of any arthroscopic surgery, and it can never be done away with. We all have to be, be able to read MRI on our own, not depend entirely on the radiologist's report, as they sometimes reports can be erroneous and that can result in suboptimal results of the surgery. It's very important to identify the medial corner injury, as you can see the picture on the left. There is a buckling of the superficial MCL, a complete tear from the tibial attachment, which is also called the Stenner type lesion of the MCL. So this patient underwent the stage 1 MCL reconstruction, followed by ACL reconstruction 2 months later. And injuries of the posterolateral corner also very frequently missed because structures are not very well defined there. Again, importance on stressing the clinical examination and the examination and anesthesia. So it's very important to identify structural damage on medial or lateral side. Complications can result if the meniscal tears are not picked up properly or not treated properly. The patient post-operatively after an isolated ACL reconstruction without addressing the meniscal pathology can have persistent posterior joint line pain. It's very important to assess coronal and sagittal sequence on the MR, and of particular importance is to pick up ramp lesions. Ramp lesions, though were neglected earlier, are coming into focus now in a big way. Ramp lesions is a tear of the meniscus, especially the medial meniscus, along the attachment to the capsule. One has to go through the to the posteromedial corner of the knee, either through bicrusting or through the posteromedial portal, and identify the medial meniscus, the posteromedial part of it, especially in every case, so that we don't miss out on these ramp lesions and meniscus tears. And we should be, no matter what, the sensitivity of meniscus of MRI in picking up a lateral meniscus tear in an acute setting is only 70%. So that means 3 out of 10 cases of lateral meniscus tear are missed by MRI. So it's very important that we do a thorough diagnostic arthroscopy to pick up especially lateral meniscus tears and ramp lesions when we are doing our diagnostic. And it's important to be ready with all the armamentarium that is necessary for doing a meniscus surgery. We need to have all angled meniscus biters so that we can reach every corner of the meniscus and address every pathology, and be aware of how to do various kinds of meniscus repair. That was pre-operative complications. If you don't examine properly, if you don't read your MRI properly, what can happen? Then there can be complications during graft harvesting. There can be the theoretical chance that the graft can get dropped from the operative table. Luckily, it hasn't happened to me ever. But there have been, I have seen that happen with bone grafts during medical college. So yes, it can happen. The graft can slim out of the table and fall down. So what do you do? What do you do in case that happens to you? The literature suggests that you've got to wash the graft. If you want to use the best option is to use another graft. Okay, this is not non-union surgery where if we take out the entire fibula is lost. We have other graft options. The recommendation in case the graft gets dropped is to take another graft. It can be the contralateral hamstrings if you're using hamstrings as a primary option, or it can be the ipsilateral bone, patella tendon bone, or central quadriceps tendon, or peroneus longus, as your choice might be. The recommendation is to leave the graft on the floor and use another graft in case you drop the graft. The literature on using the same graft is you've got to wash it with at least 5 liters of normal saline and dip it in 2% fluorhexidine solution, which is our microshield hand rub, for about 15 minutes. And there have been published literature where the grafts have been used. The infection rates are also relatively less because it's an arthroscopically done surgery, a minimally invasive surgery. But better to not have this complication. If you have this, better to use other grafts. Then there can be complications while harvesting the bone graft. Most common complications happen while harvesting patella tendon or quadriceps bone graft. If the bone cuts are not beveled properly during harvest, this is one of the cases where one of our faculty members in medical college was operating, and they used to use bone patella tendon bone with an extensive portion of the bone from the patella. Incidentally, there was a patella fracture. It was a vertical fracture. We had cannulated cancellous screws there available from the other trauma setup. We fixed that, and the patient did well post-operatively. Yes, complications with the patella can happen. More commonly, bone patella and bone graft. it's important that you have all the armamentarium to address those complications. Have cannulated cancellous screws, 4 millimeter in your setup, and have K wires and this wire ready while you are doing bone cutlet and bone grafts. Then hamstring grafts. Hamstring graft, when we are harvesting hamstring graft, you might accidentally ampute the hamstring graft much shorter than where you actually wanted it to. So that results in a shorter graft. So what is the minimal length of graft that you need? You need at least 18 centimeters of cementinosis. Uh, what I use is a triple 70 and a double gracilis most commonly, and quadruple cementinosis if I get more than 32 centimeters of cementinosis. But in case you amputate your graft short, so you need at least 18 centimeters of graft so that you can double it. You get a 9 centimeters graft of cementinosis. Add a gracilis to it if you're using hamstring talking, and you can augment it with fiber wire uh, as and when required. For beginners, since we're talking about basic arthroscopy, I'd like to make all of us aware of the presence of two tendon strippers. The open tendon stripper that is there on the below is the one which is known to cause a lot of graft amputations prematurely. Don't use open tendon stripper ever unless you are doing a MCL reconstruction where you want to retain the origin of the hamstring tendons so that you have one bony tunnel less, as can happen as is used in Lynn's method of post-operative corner reconstruction. Always use a closed tendon stripper, remove the insertion of the tendon, then pass it so that the chance of amputation is less. Identify the vinculae properly. The vinculae are what connect the cementinosis to the medial head of gastrocnemius. There are commonly two vinculae are found in cementinosis, but literature has described up to 6 vinculae. So it's important that we identify all vinculae and cut them before passing a tendon strip. And the most common complication that I come across in my patients is paresthesias in the anterolateral aspect of the knee. Can be because of saphenous nerve injury. It can be either injury to the terminal branch of the saphenous nerve or the infrapatellar branch of the saphenous nerve. So this can be avoided by careful intraoperative technique, blunt dissection, not using any sharp retraction until we can identify a graft. This is the course of infrapatellar branch of saphenous nerve which generally gets injured. Oblique incisions, as far as literature is concerned, is produce better results compared to vertical incision. Not that vertical incisions are bad. I am a person who uses vertical incisions only. But literature-wise, oblique incisions are better in terms of lesser chance of injury to the infrapatellar branch of saphenous nerve. And functionally, there is no difference in outcome if the saphenous infrapatellar branch of saphenous nerve gets injured or it doesn't get injured at around 6 months post-op. Pregabalin and nortriptyline do help. This is our general graft incision. So, in case the infrapatellar branch of saphenous nerve gets injured, that area on the anterolateral area of the leg becomes numb. Those nerves will never regenerate, but over a period of 6 months to 9 months, the nerves from the other area will start innervating that area, and most patients have significant symptomatic improvement by about 6 to 9 months. Those were complications related to graft harvesting. What would happen if what complications can happen with graft sizing? Graft sizing is never an issue with hamstring graft unless we amputate them before. Graft sizing is an issue with bone cutlet and bone graft most commonly. So there can be a mismatch in the bone cutlet and bone graft's length and the tunnel length. So this is the bone cutlet and bone graft generally. uh, the the patellar side generally goes into the femur because it's much easier to manipulate. The central part of the patellar tendon forms the new ACL, and the tibial plug forms the tibial insert. So this is the ideal scenario where we get a 2 centimeter bone plug from the patellar side, about 3 centimeter bone patellar tendon patellar tendon, and the rest of it will be tibial graft. So that is the ideal scenario. But what happens? What happens in a scenario where you get a really long patellar tendon? What would happen then is, if we go with the standard insertion technique where we put only the bone plug into the femur, we'll have a huge length of patella tendon, and the entire tibial bone plug will be outside the joint, outside the bone tunnel. So it is very imperative. We are very concerned about measuring length in hamstring tendon, how much length we got, but it is equally imperative to measure the length of your the patella tendon graft, because that will make you decide whether you want to push your bone plug inside further, or you want to go with the standard technique. So in case you realize that you have more than adequate, the adequate is around 3.5 centimeters of patella tendon length. If you get more than 3.5 centimeter, you have to push your patellar bone plug further deep into the femur, so that you get bony hold on the tibial tunnel as well. Then the other complication that we commonly come across is where we push the tibial tunnel, where we put the tibial tunnel. We all know tibial tunnel ideally has to be at the footprint of the earlier ACL stump, and that roughly conforms to the posterior margin of the lateral meniscus, anterior horn of the lateral meniscus. So, what would happen if we malposition our tibial tunnel? The picture on your left is when we accidentally malposition the tibial tunnel to anterior. That would prevent the knee from going into complete extension, and that would uh, present a lot of pain to the patient when they go into full extension, and excessive pressure on the ACL graft when in extension, and eventually leading to ACL graft failure. So in case we accidentally malposition our tibial tunnel to anterior, then we can, the advantage with the tibial tunnel is we can play around with the position of the screw. If there is adequate bone in front, we can place our graft posterior and the screw anterior, so that we can push the graft posteriorly. What happens if if the tibial tunnel is placed very posteriorly? That can result in a lax graft inflection, and that can result in PCL impingement and pain again, and result in graft failure. So this is how you assess whether your tibial tunnel is properly placed in a post-op X-ray. In a fully extended knee, when the Blumensa's line is extended distally, the anterior margin of the tibial tunnel should be posterior to the Blumensa's line. And if you're worried that it might have happened intra-op, one can take a C-arm image in a fully extended knee, see where the tibial tunnel is lying. If it is grossly abnormal, one can try to make a new tibial tunnel or place a screw anteriorly, so that the graft is pushed more posteriorly, so that we can achieve a little more anatomical position. Coming to malpositioned femoral tunnels, what happens in case we place femoral tunnels in less than recommended position? If the femoral tunnel gets placed too anterior, there is loss of knee flexion and graft impingement, because it is occupying more of the notch. So it's important that we clear the resident ridge completely, use either an electrocautery or a radiofrequency ablator or a shaver to clear the entire width of the femoral condyle, see where the posterior wall is, and place our femoral tunnel adequately. And if detected early, we can sometimes go behind and make another tibial tunnel, make another femoral tunnel if there is adequate length available. If the femoral tunnel is placed too posterior, there can be a blowout of the femoral tunnel. So this is what happens if we place our femoral tunnel too anteriorly or posteriorly. The recommendation obviously is to place the tunnel to perfection. In case we don't do that, we place it too anterior, then the graft tends to become loose in extension, and the graft tends to become tight in flexion and doesn't stay isometric. And if we place it too posterior, like the blue mark, it becomes too tight in extension and too loose in flexion. How to prevent femoral blowout? Femoral blowout is a huge complication if you're using interference screw fixation on the femoral side. So again, this is why it's very imperative to have at least 90 degrees of flexion pre-operatively before taking the patient into surgery. If we have less than 90 degrees of flexion pre-operatively, and it's a relatively chronic case, then we can't flex it beyond another 10 degrees under anesthesia. with less knee flexion, the femoral tunnel tends to come out posteriorly and there can be a blowout. So important to get at least 90 degrees of flexion pre-operatively so that we get another 10 degrees or 20 degrees in anesthesia in a chronic case. Supposedly we blow out the tunnels on the femoral or the tibial side, and the fixation is inadequate. It's very imperative to have a certain set of implants in your bag, so that autoclaved and ready to use, so that in case there is a blowout on the femoral side or the tibial side, you can use them. One among them is a suture disc, onto which you can tie your graft in case it is very loose through the interference glue, or you can have a suture post and tie it around that. What would happen if we blow it out on the femoral side? We are using an endo button and we blow out on the femoral side. There is an option available with certain implant providers of an extended endo button. Supposedly we blow out on the femoral side, the extendo button or the extended endo button can be used, and it sits on 8 mm, 9 mm tunnel also to provide us with the aperture fixation. Certain common scenarios that we occasionally come across. This is anterior screw. This was picked up post-op. The screw was quite anterior. The ideal thing would have been to identify this happening pre-operatively, but we picked it up post-op. So this patient, we had to delay the rehab, and subsequently this patient finally had good functional results. Something we come across once in a while is if there is a overzealous pull on the endo button from the femoral side, it goes up and sits there a little away from the cortex of the bone. So what do we do then? If picked up early, we can pull it down hard and then fix it. But if it's picked up on the post-op X-ray, there will be a certain degree of laxity, and there may be a little bit of suboptimal results in the post-op period. So these are common complications that we come across, and there's a saying that truth can be stranger than fiction. So there are complications that you can have during surgery, and then there are certain mother of all complications. This is a call I got from one of my colleagues where the guide wire got left inside. I can find it a little hard to imagine how this can happen. Most likely it was that the screw would have pushed the guide wire inside, and it's not even the CM image, this is actually the post-op X-ray. So I was called in for this particular patient. Luckily, the guide wire had not injured any of the structures proximally. The neovascular structures were okay. We were able to go into the joint and retrieve the guide wire through the screw, and it came out, and finally the patient didn't have any issues, and the patient didn't create any issues also. Post-op complications can be infection, which Dr. Francisco will be taking care of, and stiffness is one complication. It's very important for the anesthetic team to be extremely competent whenever we are doing ACL surgeries. All these are extremely painful surgeries, though they may not appear through the skin incision that way. Patients are extremely painful on the first and second post-op day. We have to have a wonderful backup of the anesthesia team, which will give a good pain relief post-op, so the patient starts exercising from day one, and the chance of stiffness are much less. So I end my talk by discussing how to avoid major complications. It's very imperative that we do a proper clinical examination in the outpatient setting and after anesthesia. We always correlate with the imaging technique and have a recent image before going into surgery. Very important to identify all the anatomical landmarks and base our tunnels based on that. Meticulous technique while doing a graft harvest, using a sterile technique to prevent infection. Use quality implant and quality instruments so that you don't end up cutting the sorry figure into the patient post-operatively. However, said that, life teaches us a lot of lessons. We should take it in our stride and keep trying to better ourselves. This is one quote I love from Alvin Toffler, which says that illiterate of the 21st century will not be those who cannot read and write. Illiterate of the 21st century will be those who do not learn, unlearn, and relearn. So let the journey of learning continue for all eternity, and let us be wonderful students for our life. I would like to thank Saseendar and Dr. Srinivas for providing us the opportunity to share some of our experience on this wonderful platform. Thank you very much. You're doing a great job. Keep it up, Dr. Saseendar and Dr. Srinivas. Thank you.
Thank you, Dr. Vinay. Can you stop your share screen?
I will do that right now.
Yeah. Okay. Thank you, Dr. Vinay. It was a very comprehensive talk. It was impossible to talk everything about the complications of ACL reconstruction. We have in 1 hour or half an hour or even 1 month. So we have been doing talks on knee ACL reconstruction alone since the past 1 month. So obviously, it's a very big talk, big section, and it is not possible to cover everything about the complications of ACL reconstruction in one talk, but this is a basic program, so we have tried to cover all the basics that is needed. We have been discussing and we will be discussing the more specific points in each and every other program. And Dr. Vinay, thank you very much for a very comprehensive program. You tried to put in all basic things that need to be done or considered with respect to doing an ACL reconstruction. And after an ACL reconstruction, it is very important to know what not to do before you decide what you want to do. So thank you very much. You discussed on early versus late ACL reconstruction issues with the choice of graft, the placement of the graft, the placement of the tunnel in the femur, and also in the tibia. The tunnel can be too anterior or posterior. There can be a blowout, and same way, it can be too anterior and posterior in the tibia, and there can be a blowout anteriorly in the tibia also. And there can be implant-related complications, and there are specific implants that can help you tide away from the complication. You need to know the options in order to uh, escape from difficult situations inside the operation theater. And it is also important to know about stiffness parameter that you should know both pre-operatively and intraoperatively in order to prevent a stiffness. For example, you choose the patient properly, you choose when you want to do the surgery, you make a clear diagnosis. The diagnosis has to be complete. It's not just an possibly the patient doesn't have just an ACL tear. He has possibly a lot of other issues. If the patient has a chondral injury, he is possibly going to fare for after the ACL reconstruction surgery. Similar, the same way with meniscal injury or even collateral injury. With the collateral injury, you need to give time for the patient to get back to a good range of motion, at least of 90 degrees. Uh, or for that matter, any other knee injury that has been a high energy injury, you need to allow the knee to become stable or cool down, get it to good range of motion, and then you need to proceed with the surgery. So choosing the patient, choosing the time when you want to do the surgery, making a complete diagnosis, all those are very important. Okay. So we will go on now to a very important part of the talk, that is infection after ACL reconstruction. Infection after ACLR is fortunately not very common, but this is something that is very dreadful. ACL reconstruction, it is, I consider it it is an essential surgery for a lot of people, but at times I consider it as a quality of life surgery. You are doing the surgery for not for living, but to live a good quality. So infection in such a situation is something which we are dreaded of. So we need to know how to prevent and how to treat infections in ACLR. So over to Dr. Francisco. Welcome, Dr. Francisco. You can share your screen and proceed with your talk.
Okay, so thanks for the opportunity. I will talk about infection after ACL reconstruction, focusly mainly on prevention more than management, because I think management is much easier and prevention is the key. This is my two hospitals. First, the largest private hospital in my country and one of the most important in South America. And the second one is the largest public hospital in my country and we receive visitors every year from all over the world, so you are more than welcome to come. Luckily, infection after ACL reconstruction is not common. The complication has incidences that vary between 0.1 or 1%. But the main issue is that even with a state-of-the-art treatment, there is risk of graft failure in the long term, arthrofibrosis, articular cartilage loss, and even sometimes you have to remove the graft. So an early diagnosis and an aggressive treatment are crucial to avoid potential complications. So where do you have to focus? And I think the ideal case to never have to deal with this complication. So I will say that probably the main focus of this is the prevention of the infection more than the treatment, but I will talk about treatment too. Sorry, it's not there is. So about prevention, first of all, I have to say about tobacco that there are some studies, and this one is a big one on almost 1,700 patients that underwent an ACL reconstruction compared to match controls, all tobacco users, and the incidence of infection was 2 times higher for patients who use tobacco versus the control patients. So the main recommendation here is that tobacco has to be stopped before an ACL reconstruction. So you have to recommend it to every patient when you are operating. What about IV prophylactic antibiotics? There is this systematic review on almost 50,000 patients who underwent knee arthroscopy. And as you can see, there was a twofold larger infection rate in patients who didn't receive IV antibiotic prophylactic antibiotics in a prophylactic way. So and this systematic review is made on patients only in simple knee arthroscopy without the graft procedures, but you can take or you can apply the evidence from this to more complex knee surgery. So the recommendation here is to use prophylactic IV antibiotics always before an ACL reconstruction. What about drains? And this is an interesting systematic review about the use of drains in ACL reconstruction. And they found no differences in the occurrence of wound healing complications, infections, or the number of aspirations for hematoses while using or not using an intraarticular drain. So I think that if you have a foreign body that is doing nothing and you're not gaining any positive effect from this, probably it's obviously not recommended. So I won't recommend to use a drain after ACL surgery. What about the graft choice? And this is a really large study, a really interesting study from the Kaiser Permanent Registry on almost 11,000 cases that showed that hamstring tendon autograft had the highest incidence of the infection of all graft types. While on the other side, patellar tendon autograft had almost no infections, and allografts are in the middle between both kind of grafts. So, and when an statistical analysis was done, the likelihood of a patient with a hamstring autograft of having a deep infection was 8 times higher than someone receiving a patellar tendon autograft. So. Finally, the recommendation here is that if it's possible, try to use patellar tendon graft because the infection rate is much lower than hamstring. But obviously, this is not possible in every patient. For example, in our personal series, we use about 10% of patellar tendon graft because patients they don't like the graft because of the morbidity associated. What about clinical pathways? And this is another really interesting study about an institution in the United States that in 1 year they had a 4.4 rate of ACL infection, and they had to suspend or to cancel all the surgery in that institution because of this. And they did a big process review, and they identified some shortfalls in the way they treated the ACL surgery, and especially that more than 1/3 of the cases of infection after ACL reconstruction were associated with the use of flash sterilization. So they performed and they did a pathway that included performing exactly the same perioperative care in every case, some early discharge and no use of flash sterilization. So they prohibited to use to operate more ACLs than trays available at a day. And after implementing this pathway, they had not known infections in 3 years. So it was a big success. So I think it's important to try to do the same in every case and have like a clinical pathway written or in knowledge of all the personnel. There are a couple of studies on antibiotics in the irrigation solution, and especially in this case is gentamicin, and they using this protocol, they found a 10-fold decrease in ACL infection. But we know that the gentamicin is really toxic. They didn't report any toxicity effects, but there was some concern about the toxic effect on the cartilage at long term and some long-term toxicity because of the antibiotics. So I think should be more studied, but it is interesting. What about our experience with infections? And we have published this study that reported all our infections from 2000 to 2011. And in that period, we had 7 septic arthritis in almost 1,600 patients, accounting for a 0.4 infection rate after hamstrings ACL reconstruction. And at that time, we were doing only 4-strand reconstructions. But all our problems started when Bob Magnussen from Ohio published this mainstream study about the relation of graft size with early revision surgery in ACL reconstruction. So after this, we stopped using grafts smaller than 8 millimeters, and we had to develop techniques to deal with this complication. So we started folding the graft in more strands, and we started developing some 5 and 6 strands grafts. We published our experience, and it obviously included more manipulation of the graft and a longer preparation time, as you can see in the pictures. And we were really happy with our new thicker graft, but the main issue that we had initially was that our ACL infection rate increased from 0.4 previously to 1.7. And we could blame the surgical nurses, the residents, the fellows, but probably the main issue was the new graft preparation that we were doing. Luckily for me, during that time, I traveled to Colombia to a meeting, and I met Dr. J.C. Monjao from Barcelona, and he presented this paper in the meeting about the autograft soaking in vancomycin to reduce the risk of infection after ACL, and he had no infections after a period of a lot of infections. So for him was a really big success, and doing all the research, we found that it was already published by Chris Bertolo from Australia in 2 different studies on almost 1,300 patients. and he didn't have any infection too. So it looked like a really promising technique. So we started, we thought that at that time that we found the light at the end of the road, and we started using that technique, and that is really simple. Is just adding some 500 milligrams of vancomycin to 100 millimeters of normal saline in a tray, soaking a sponge of a Rytec with this solution, and then after the graft is prepared, covering the graft with this sponge, while the main surgeon is doing the channels and all the arthroscopic ACL procedure. So we kept our 5 and 6 strands graft, and we add vancomycin. We published our experience in OJSM, and following the same trend of Dr. Monjao and Dr. Bertullo, we had no infections when using vancomycin pre-soaking, and we were really happy. After our study was published, a lot of different studies on the same topic had been published in different journals, and I will stop in this one because this special study that was made in the United States in Iowa, and it focused in different grafts in different kinds of ACL procedures and some associated ligament procedures too. Reported the first and only case in almost 8,000 patients with a vancomycin pre-soaked graft. So unluckily, they didn't publish any information on the case. They didn't report any information to know, for example, which kind of graft the infected patient received, or which kind of associated procedures. But still, with that infection case patient, they had a 10-fold reduction in the infection rate after ACL surgery. So it was still a success. Then a couple of one systematic review and one narrative review appeared, and we are also working on a systematic review to account for all the new studies available. At the same time, a couple of studies of biomechanical studies appeared, all the two of them stating that the use of vancomycin is biomechanically safe, at least in time zero. But the main issue, I think, is that it's not widely used, and I don't know the reason. Probably it's lack of publicity. And you can see here that this survey to surgeons from the Swedish Knee Register accounts for only an 8% of use, and it's really weird that that low percentage, because it is an inexpensive and highly effective measure. So I think we have to do more publicity to this technique. So as a summary of prevention, I will say that if you want to decrease your infection rate, you have to stop tobacco. You have to use always IV prophylactic antibiotics. If it's possible, try to use a patellar tendon graft because it involves less manipulation of the graft. Try to do always the same. Try to follow some clinical pathways, and never operate more ACLs than available trays in the same day. So don't use flash sterilization. And probably the most important recommendation is to try to always use vancomycin pre-soaking in hamstring graft, and especially if you are going to over manipulate the graft, as in a 5 or in a 6 strand graft. And if it's possible, try to use it in every graft. We use it in every graft, in every ligament procedure, really. So the future directions in this probably is to study the effect of vancomycin in the long term. But there are there are studies that found no clinical effects at 2 to 3 years compared to non-vancomycin patients. And about gentamicin irrigation that I talked before, I think it has no role after vancomycin presoaking technique appeared. So I will say probably someone can study that, but I don't think it has a role really. About management, and this is the complication no one wants to have. The diagnosis is not difficult. It's usually a patient that is doing fine after an ACL reconstruction and suddenly starts with swelling, effusion, pain, and loss of range of motion. And typically it happens between the first and the second week and the second postoperative week. And you have to have a low threshold for knee aspiration in this kind of patients, and always taking blood samples for inflammatory parameters to monitor the treatment. The diagnostic criteria of the synovial fluid is the same that for primary septic arthritis, so I won't go further in this. And after you have the confirmation of the synovial fluid analysis or the suspicious, you have to go into the main treatment, that is an arthroscopic debridement plus antibiotic treatment, but the antibiotic treatment should be initiated after taking intraoperative samples. Okay, that's probably the most important thing. So, and as I said before, taking samples before starting antibiotics is of mainstream importance. And the debridement has to be extensive, taking all the vitalized tissue, removing fibrin clots and a large synovectomy. And it is also suggested to remove the fibrin layer covering the graft and to evaluate the macroscopic integrity of the graft as well as the tension of the graft. And if the graft is not viable, it should be removed at the first time, along with all the fixation hardware. So what is a satisfactory outcome after doing your first debridement? Usually a decrease in CPR levels and improvement in the clinical signs of infection. I mean pain, better range of motion, and less effusion. But what happens, and what you have to do in the case this is not happening, you have to do a new arthroscopic debridement. And there are no specific recommendations for graft removal, but usually if you are already have done 3 to 4 lavages, you still don't have a favorable outcome. You have to remove the graft. So and probably then you will see what to do with the patient. Luckily for us, the salvage or the retention of the graft is possible in about 80% of the cases. So it's not that bad, and it's really important to try to save the graft because the clinical outcomes are much better in patients where the graft is retained. And the same happened in our experience. As you can see in the first 5 patients, we were able to save the graft and the leave home scores were much better. And it's also important that we were able in these patients to diagnose the infection really early, and that's really important because if you come early, you have more options of being able to retain your graft. And as you can see in case 6 and 7, we took a lot of more days, and we weren't able to save the graft. So as a summary of management, I will say that luckily for us, septic arthritis post ACL reconstruction has a low incidence rate. And if it's handled at an early stage, it allows patients to get a satisfactory return to their previous activities. Probably one of the most important things is to have an early clinical suspicious, because it will be important to achieve a timely diagnosis and to be able to retain the graft. That is probably the most important factor in obtaining better functional results. Thank you very much, and thank you for the opportunity to both panelists.
Thank you very much, Dr. Francisco. you can stop your screen share.
Let me do it. Okay,
Yeah.
done.
Thank you very much. That was a very interesting talk. There were quite a bit of interesting information that you shared. With respect to prevention, yes, definitely tobacco is it's a very important factor that can impede in healing and thereby also increase the chances of infection. Antibiotic coverage is definitely an important factor that reduces infection. Drain, yes, there is no conclusive evidence that use of drain has improved or reduced the rate of infection. It's quite interesting that hamstring grafts are associated with 8 times higher risk of infection than patella tendon. That's quite new to me. And gentamicin in the saline, that's also quite interesting. Also, we would like to remind the audience that Dr. David Figuera, father of Dr. Francisco Figuera, in his talk on evolution of ACL reconstruction, he also talked about soaking the graft in vancomycin, and he also shared the paper. Most of the people in the Facebook page would have gone through the paper. That's a very interesting paper, and it's quite nice to know that more and more institutions have started taking up vancomycin as soakage for hamstring graft, especially. And it's also heartening to see that the infection rates have come down very much. Okay, and with respect to DVT, I do have some reservation because yes, avoiding DVT is very important, but the incidence of DVT has been very different in different population. But it is something that we need to be very careful. You need to have your own register in your own location. Make sure you are addressing all the important parameters. And with respect to the treatment, yes, identification of the infection has to be very early, and make sure you don't give antibiotic before you make a clear diagnosis on the organism that is causing the infection. And it's also interesting to know that you need to remove the fibrin layer over the graft when you do the debridement. And fortunately, graft retention is very highly possible after infection in the after an ACL reconstruction. Okay, that was a very interesting talk, Dr. Francisco. Thank you very much. We have a couple of questions. I think I will take the questions to Dr. Vinay first. Okay, Dr. Vinay, you did show an image of the button in the soft tissue on the femoral side.
Yes.
Okay. What is your experience in your practice so far? Have you had the experience of having patients who had problem because of soft tissue in the button in the soft tissue? Is there a way to, your tips and tricks of ways to prevent the button in the soft tissue? And did you have to go in again and recorrect it, or what can be the complications of button in the soft tissue? Can you talk more about that?
Yeah. The one X-ray I showed, there was only a 1 millimeter or 2 millimeter
Yeah.
of the graft in the soft tissue,
Yeah.
the button in the soft tissue. Those patients have not come back with any complications.
Yeah.
Frankly, 80% of my practice is general population, and about 10 to 20% are sports persons. But my belief is that it does increase the laxity, even 1 to 2 millimeters of the button staying away from the cortex, and it would affect the performance of a sports person. But as far as the general population and the relatively sedate population is concerned, you don't need to do anything about that. I've had one episode where overzealous, assistant tried, pulling the graft in, and he flipped the button beyond the ilioptibial band. So the button got flipped superficial dilative band. We suspected that, We took a CM image. It was obviously on the tibial band. We gave an incision on that area, opened it, and replaced it. Apart from that, 1 to 2 millimeters. Sometimes the periosteum is also quite thick in some patients, so it can give an image that the button is sitting away from the bone. But in case you pick it up on the post-operative X-ray and it's only 1 or 2 millimeters, then you don't need to do anything about that. The way of preventing is to have proper markings on your closed loop. You have to measure what your tunnel length is and mark on your closed loop if you're using a closed loop as to until when should you pull it, and have markings on your graft also. If you're using adjustable loop, then again you need to mark the length of your tunnel. Marking the loop, adjustable or closed, is probably the most important step in identifying until where you pull. I don't recommend using a CM in every case.
Yeah, thank you very much, Dr. Vinay. That's crisp and clear. Dr. Francisco, do you want to share anything on the button in the soft tissue on the femoral side?
Yeah, I want to say that my good friend Alex Weissman, you know him, he's doing a study about that, and until now this is not the final results, but it's some preliminary report, and he has found that if it's not that far, it doesn't matter really. That it's not it doesn't affect any clinical results or any revision rate or any so maybe there are some laxity differences, but the way we measure laxity is not good too. So it's difficult to use because we have measurements for laxity, for example, the KC 1000, but it's a really bad method. I think I have seen a lot of studies that where it usually it's not reliable. It's not reliable at all. So, and at least in clinical results, Alex has found that there are no differences if the button is flush with the bone or is a bit far. And another thing I want to say is that my fellowship director in Australia, Dr. David Parker, he's the vice president of ISACOS right now. He was a perfectionist, so he used X-ray fluoroscopy in every ACL case because he didn't want to get a control X-ray, a follow-up X-ray, and find that the bottom was not flush. So probably if you are a perfectionist and you don't want to ever have a bottom apart from the bone, you can have X-rays in the theater. And if you don't mind, probably you won't have any different results. That's what Alex found.
Okay, Dr. Srinivas shared on this.
Sorry, about this one.
About button, yeah, in the soft tissue. What's your experience? Have you had a situation this has happened?
Not much really. I think most of the time I was able to avoid it in most of the cases by putting my scope in the femoral tunnel, and I watch the button going out of the tunnel and flip. So I know where exactly the button is. So I haven't seen, since I started this practice, I haven't seen any button in the soft tissue.
Okay, I would like to share a couple of experiences of my own and my friends. I have had one particular situation when the bone has passed beyond the iliotibial band. That was a very bad situation. That was very early in my practice, and that does restrict the range of motion that is possible in the iliotibial band gets bagged, and it's very obvious in the X-ray. The iliotibial band is sort of puckering in the X-ray. You can actually see the iliotibial band getting impinged into the femur. I had to go in and correct it. Okay, so that was one situation. However, there have been, as Dr. Francisco said, and possibly what I understand by not having any complications of the button and the soft tissue are possibly the milder categories. With like a couple of millimeters of gap between the button and the femur, I would definitely agree that it's not going to affect the outcome. And I do not do X-ray for all my patients, almost none. I don't do X-ray for any of my patients. And we recently sort of identified a simple test. I would like to call it as a springing test, which I do for all my patients after flipping the button in the femur. What I do is we have a mark on the thread of the button and possibly on the graft also, but if you're using a adjustable loop, before you have pulled the graft inside, you have the mark on the thread, and when you pull, if it does not spring, in other words, if the mark is not moving in joint and into the joint and back into the tunnel, then you're not into soft tissue. If the button is in the soft tissue, because of the laxity that is created by the soft tissue, the mark gets into the joint when you pull and gets back into the tunnel when you relax it. So I have found a very, very useful test. And even when I got it positive, I even got a CM picture done just for confirmation. And it was into the soft tissue. And in order to correct a button placement in the soft tissue, it is not exactly needed to open the skin on the lateral aspect. Sometimes it is even possible to manipulate button with a mosquito and sort of pull it more towards the skin and then push it back and manipulating it with the traction on the other side, on the tibial side. It is possible to manipulate it and place it on the cortex. So this is something I found it very, very useful, and I would like to share here. And I would also like to share my observation of the surgeries by Dr. Torres and Dr. Christian Lozano in Clinica Americana in Peru. They used to go into the lateral compartment of the femur with the arthroscope, actually see the button flipping over the cortex. So it's absolute. You actually go and see the button on the cortex, and there's absolutely no doubt you're into this. So it is one technique, but sometimes when your button is going more posteriorly, it might be, I mean, when your tunnel is slightly more posteriorly directed, it might be difficult to look at the button. If your tunnel is starting from posterior to anterior, then it is very easy to actually see the button and see it flip on the cortex. Okay, so I hope this information is very helpful for the beginners. And okay, Dr. Francisco, regarding the use of drain, I don't use drain for any of my primary ACL reconstruction patients. And for the revision ACL reconstruction, I do use a drain if I'm doing a quite extensive notchplasty, because these people come with a very narrow notch, and I need to do a notchplasty and it bleeds a lot. So I use a drain. What I would like to ask you is, what is the prevalence of requiring a knee aspiration in the outpatient setting after ACL reconstruction for a persistent effusion after primary knee arthroscopic ACL reconstruction when you're
Almost
not
never.
using a drain? Yeah. Do
It's
you
really rare.
Really
I
rare?
never use a drain.
You almost
Yeah.
You
I
almost
never use a
never
drain.
have to do an aspiration. Yeah.
No, we use this kind of ice machines, like cryotherapy. These ice machines for the first day. So, and finally, if you recommend the patient to stay with the limb elevated and to use some ice, usually you don't have any problems. So So I don't remember the last time I did an aspiration for hematrosis. I think it was a long time ago. So.
Okay, that makes it a very small percentage. Dr. Vinay, what's your experience? Do you have? I mean, do you have to aspirate a couple of your patients?
I never do that.
Do you use a drain?
I don't use a drain. No, I don't use a drain.
Okay.
I had been using
Okay.
drain earlier, but then again, we had a similar study at our institute comparing drain versus no drain and found similar results in both. So I might as well have one foreign body less in the joint. Okay, so I don't use drains. And we have episodes where the knee is a little swollen post-operatively, and the patient is in a little bit of pain the first 1 or 2 days, but it generally settles. Generally settles by around the second week time, or around less than 1 month. It settles. The effusion settles. You don't have to aspirate any of the cases. Uh, good, uh, good analgesics would do the trick, and the patient will be pain free. We need to explain to them that the swelling will persist for some time, and then finally it will go off. I think the patients are more worried about the pain than the effusion. We counsel them well, they'll understand and they'll wait for the effusion to go off on its own. If we take care of the pain, they'll be much more than fine.
Okay. Dr. Srinivas, you have anything to share on this?
No, I haven't used any. I don't use any drain, and I have not aspirated as well. They usually settle, as speakers have said. So.
Okay. With respect to my experience, I don't use drain as I said earlier. I use a drain only for revision reconstructions when I need to do notchplasty. I did see a couple of not a high incidence, but possibly maybe like 4% to 5% of my patients. They don't have a large effusion, but if I feel that he is not able to get full range of motion at around 2 weeks, my effusion, I tend to have a lower threshold in order to do a therapeutic aspiration, in order to help him do his physiotherapy better, strengthen his muscles better. Yes, we do all this ice packing and all that. Yes, the effusion does settle of its own, but I tend to have a lower threshold to aspirate it if it has been stopping full flexion by around 2 weeks. So this is my experience, but we don't have evidence for the outcomes of this right now. Okay. Okay. Dr. Francisco, with respect to infection after ACL reconstruction, is there an objective way to identify which grafts to retain and which to not? Because if it is quite early after ACL reconstruction, we don't see revascularization, or we can't expect a picture similar to ACL. So most of the grafts look dead. So how do you exactly decide which grafts to remove and which to not?
Well, the reality is that I have never removed a graft. Well, I don't have. I only have mild infections of other people, because since my whole career I started using vancomycin and I have never had any infection. So I have done a couple of my colleagues, and I have never removed a graft in the first arthroscopic debridement. I think well, all the recommendations is that if the graft is really loose, or the bacteria has like eaten the graft, they like to take out the graft. But in my personal experience and the experience of all the people around me is that the graft has to be really in really bad shape to be removed in the first debridement. I think I don't know any surgeon that would remove the graft initially, because probably that's the main goal of the debridement, to try to preserve the graft. So So I think like in the only case I will remove the graft is if the graft is completely loose, or it's completely eaten by the bacteria.
Exactly. Okay. Thank you very much, Dr. Francisco. This is a question from the audience. Dr. Raghavan is my colleague actually. He has asked, do you have a cutoff for the CRP values for making a suspicion of infection?
Well, not really, because CRP is elevated because of the surgery usually, and I use CRP mainly to monitor the treatment, not to make a diagnosis. I think finally the way to make the diagnosis is obviously all the clinical parameters of a septic arthritis, and as I say, usually it's a patient that has been doing well, and after this he starts complaining of effusion pain and loss of range of motion. Usually it's like the patient was in the high part of the curve and then suddenly drops. So I think the clinical picture is more important than CRP, because CRP is only to monitor how you're going. No, it's not a diagnostic tool, I think.
Yeah. I totally agree with that. As a continuation of this question, I would like to ask whether you do CRP as a regular indication, not specifically for knee or ACL, as pre-operative assessment for any surgery. Do you do PRP test for all patients undergoing surgery pre-operatively?
Yeah, the question is for me?
Who's the question directed?
No, it's for Vinay.
Oh, hi. Yeah. No, never. I don't do CRP for any of my pre-operative patients. I am a joint replacement surgeon also. I don't do CRPs for my joint replacement cases also. No pre-operative CRPs. If the skin condition is not good, so there are certain patients who come with abrasions over the portal sites. Those patients, I don't touch them till the abrasions heal, which is generally around the 2 weeks mark. So after 2 weeks, I operate them, and I make it a point that I use iodinated dressing like an ioban or an oxide on those patients who had abrasions on the knee. Though it's healed, I tend to use those iodine drapes before the arthroscopy for those particular cases, but no CRP pre-operatively for any of the patients.
Okay, Dr. Francisco.
No, I never do CRP pre-operative. Never.
Yeah.
I don't find any role really.
Yeah. Fine. Dr. Srinivas, you have any questions?
I don't do CRP as well as a pre-operative measure. Diagnosis of infection is basically clinical. And obviously, if you have a very high CRP, say 200, 300, something like that, definitely it's infected. So, and you will see that clinically most of the times. So it can be useful in monitoring response for your treatment. So I use it for that. Other than that, I don't do pre-operative CRPs. Thank you, Dr. Vinay and Dr. Francisco. You have been excellent talks. We've covered most of the issues and complications, but it's a huge topic to cover, and we can't cover everything. There are a few things I just wanted to mention for completion's sake. One is management of arthrofibrosis or cyclops, and what is your experience of managing, say, a persistent fixed flexion deformity of the knee after ACL reconstruction, and also a restricted flexion of the knee after ACL reconstruction?
I've not had personally any case of arthrofibrosis. My own personal post-op cases, I luckily haven't landed up with an arthrofibrosis. I think the main reason for that are two things. One is we follow a very aggressive rehabilitative protocol, and the second thing is we take care of the analgesia part of it very well. which also reinforces the pain arc in the brain. So those two things, if taken care of, arthrofibrosis generally, luckily I've not come across in my patient. I've treated people who had arthrofibrosis, who had cyclops operated elsewhere. The general, it's difficult to save that graft. I've tried debriding that graft and retaining only a part of it, but you're not sure whether the graft you're leaving, whether it will provide you with adequate function. So I have the experience of operating only 3 cyclop cases. All 3 cases I have taken out the previous graft completely, and once you remove the graft, you get the full range of motion. Sometimes you might need to manipulate the knee also under anesthesia. Then I taken the other graft and revision ACL.
When do you manipulate the knee? How do you decide, make the decision on taking for manipulation under anesthesia?
These cyclops cases,
restricted extension or restricted flexion of the knee after ACL reconstruction.
Apart from established cyclops cases like the I'm talking about, I've never taken a patient into manipulation and anesthesia. I've manipulated a few MCLs of mine who become stiff. MCL repairs that I've done, that I've put them on a slab. There was one particular patient who had a deep vein thrombosis after an MCL repair and a slab application, and she went to the ICU and came back and ended up quite stiff. So under an arthroscopic guidance, I did a manipulation for that particular case. But otherwise, per se, isolated ACL reconstruction, I've not had the experience of doing manipulation in my cases.
Dr. Francisco?
Well, regarding fixed flexion deformity, I think most of the cyclops don't produce that restriction. I think the cyclops have to be really big to produce a fixed flexion deformity, but I recognize that that complication, I think it should be you should be more focused on prevention than on management, because my personal experience with the fixed flexion deformity is that it's almost impossible to manage it with a mobilization or an arthroscopic debridement. I have done a couple for patients where I suspected that there was some anterior fibrosis or any mechanical restriction. And after I have done the scope and the manipulation, I haven't gotten the results I wanted. So I think probably in fixed flexion, especially, you have to focus in preventing, be clear with the patient and telling him or she that they have to rest with the limb extended and focusing especially in full extension in the early phase. And on the other side, I think when you have a flexion restriction, that is really easily managed with physical therapy, or if after 2 to 3 months you haven't had any results, with a good scope and debridement of the scar tissue, it's easy to regain your range of motion. But I think flexion deformity is a completely different problem, and it's really difficult to manage.
Yeah, it could be malplacement of the graft, isn't it? And flexion deformity, if it doesn't get corrected. Yeah, most of these fixed flexions are very small, 5-10 degrees, and most of them get corrected in the first 2 weeks, isn't it? There's a question by the viewers: is MUA beneficial in restricted extension cases? How do you, what do you advise patients before going for MUA, or how do you advise patients to correct the fixed flexion after ACL reconstruction? You see in the clinic, when you see the patient, you see the knees slightly flexed, you want to correct it. What do you tell the patients?
Well, there are just simple exercises. It's usually I tell them to for example to someone to put their hand under the knee and try to smash the hand with the knee, or try to usually I try to use these kind of elastic bands too. So they put the elastic bands around their feet, and they do some extension exercises that way. And well, there are a lot of exercises, but usually I help myself with a physical therapist. So I don't do anything like by myself, and I don't let the patient do it by themselves too. I almost put them into the hands of a physical therapist.
Would you do manipulation if it doesn't get corrected? I think that's what the viewer wants to ask.
I will do, but usually, I think, well, I think it's not really beneficial, but I will do it because I think it's important to. I think you can't wait eternally. So, and I have a lower threshold for this. So, I think if after 1.5 months it's not resolved, I will do a manipulation trying to at least to eradicate any possible mechanical problems. But as I said before, I don't do it well. I haven't had this complication really often. I think only one case in my life, and I have a couple more, but in tibial spine fractures, that is a bit more common, and I still think that manipulation and debridement doesn't really work. So I do it, but with not really convinced. That's the reality.
Dr. Vinay?
As Dr. Francisco has already said, I personally feel there's no role for manipulation of feature for ACL reconstruction. Most of them stretch out with dedicated physiotherapy. I've had the experience of doing manipulation under anesthesia for other cases like malunited fractures and certain multi-ligaments. In those cases, I would first go inside the joint with an arthroscope, clear all the intra-articular adhesions and whatever is preventing the movement. Only then come out of the joint and then start manipulation. So those are for general manipulation under anesthesia cases. Always an arthroscopy first, clearing all the intra-articular adhesions, then come out and do the actual manipulations. But no experience of doing any manipulation for ACL reconstruction. Don't recommend also. Don't think it's necessary. Almost everyone will stretch out with physiotherapy.
Sasi?
I have very minimal experience with manipulation. I almost never had to do manipulation. Talking about my own patients, I've never had to do a manipulation for them. As I said, I do have a smaller threshold for aspirating the knee if they don't full flexion at 2 weeks, but none of my patients had extension deficit, possibly in the sense that required a manipulation, possibly maybe 0.5% of my patients possibly had tightness related extension deficit. They almost always recover with physical therapy. These are patients who fared poorly with respect to the compliance. Most of the time that is the case. And beyond that, I mean, in general, if physical therapy has not improved your extension deficit or yes, flexion is a different ballgame. Specifically the extension deficit, then the problem is 99% in the placement of the tunnel, not possibly any other reasons. Most likely, the non-compliance related flexion deficit is flexible, or it gets corrected with physical therapy. The more tight ones, they are almost always because of tunnel placement. Yes, deficit in flexion, that is restriction of flexion, is a very, very common problem that again is most commonly is possibly related to the physical therapy protocol that is being carried out, or non-compliance to the physical therapy by the patient.
Okay. Any experience with synovial fistulas? Any of the speakers? No.
So I have seen one, but it was not mine, but not after ACL, after a lateral release, arthroscopic lateral release. And finally, it wasn't difficult to correct it. Finally, the only thing we did at that time, we put some stair strips on the patient wound, the arthroscopic wounds, and we asked him to stay in extension with a knee immobilizer for about 3 weeks, and we gave him antibiotics, prophylactic antibiotics, because my father, he had one like 10 years before, and it became infected. So but usually just with extension and with immobilization, extension, and antibiotics, it resolves. So I think it's more scary than anything.
Okay. And also medial and lateral placement of the tibial tunnel. How do you avoid injury to the anterior horn of the lateral meniscus? How do you choose your point for the tibial tunnel?
Question for Vinay.
Both.
The fresh cases, you invariably tend to have the tibial stump. So the basic idea is to come through the center of the tibial stump. You correlate all the available anatomical landmarks. It should come through the center of the tibial footprint. It should come out at the level of the posterior horn of the anterior margin of lateral meniscus, and mediolaterally it should be in between the two tibial spines. So try to match all three criteria, and it should be matching all three criteria. And then still, if you find that it's not properly placed, again reposition your guide wire. Sometimes what happens, you already positioned your guide wire, you want it a few millimeters, this side or that side, and the guide wire tends to slip into the same pilot hole all the time. So in that particular time, you've got to move your tibial jig outside more medially or more towards the center, so that you get a new entry point. Once you have a new entry point, it tends to go and fall back in the place that you want it to. So once you're done with that, then you drill your 4.5 or 6 millimeter tunnel initially. After that, also, in case you're feeling that your tunnel is more anterior, more posterior, you can try to bring it forwards or back by holding your guide wire intraarticularly with an artery forceps. You want the tunnel to come more anterior. You bring your guide wire more anterior and try to drill it, so it comes a more anterior, more posterior. Once you're done with the whole thing, then you realize that your tunnel is anterior or posterior. Then you can play around with the placement of the position of the screw. If you feel that the tunnel is very anterior, you want your graft that should have been posterior, put your screw anterior to the graft so that the graft goes posteriorly. I tend to use that more with the PCL femoral tunnel, this technique. I've not had this issue with the ACL tibial tunnel. PCL femoral tunnel, sometimes I feel I end up making it more anterior and more posterior. So I play around with the position of the screw to bring the graft either anterior or posterior. So these are certain things you can keep in mind while making the ACL tibia.
Dr. Francisco?
Well, I always try to leave the ACL stamp. So finally, that's my main focus on where to put the ACL tunnel. So initially in my career, I used this rule about like the trying to put the tunnel relating to the posterior aspect of the anterior horn of the lateral meniscus. But I think it's not real. It's not completely real, and it doesn't apply to every patient. So finally, I think preserving this stump is the easiest way to get the tunnel where it really goes. So, when you preserve the stump, you can have a bit more cyclops complications, but at least to me, for me, it's not a problem. So that's what I do, really.
Okay, I agree to what Dr. Francis says with respect to the anterior horn of the lateral meniscus. It's I wouldn't say it is a very good reference for ACL, but yes, it is a fallback. But in my experience, almost 100% of the cases, you have a stump on the tibial side. There is in 50%, more than 50% of the patients don't have a stump on the femoral side, but on the almost 100% of the patients have a stump on the tibial side. I don't remove all of it. I just have a small part of it, and I go in the center of it. It becomes anatomical.
And of course, you can also have complications related to your equipment. And I think we have covered that in our basic arthroscopy talk. The monitor not working, the scope not working, shaver not working.
Okay, these are surgeons' complications, not patients' complications.
Yeah. In hospitals, complications. Surgeon is never at fault.
Yeah.
There's no substitute for
surgeon is always right.
Before you start the surgery. So yeah, that's a very good discussion. Thank you very much.
Yeah. Okay. So thank you, Dr. Vinay. Thank you, Dr. Francisco. It was a very, very good discussion. I think we covered most of the basics that any beginner or a mid-level arthroscopy surgeon has to know with respect to ACL reconstruction or knee arthroscopy in general. I hope to see both of you sometime soon in our future programs. Thank you very much.
Of course. Thank you very much to
Thank you very much.
Yeah, and thank you, Dr. Srinivas.
Keep up the good work. Thank you.
Yeah, thank you.
Thank you very much for the invitation.
Yeah.
Have a good day.
See you. A pleasure. Good day. Thank you. Bye.